Hello, everyone, and good evening. Welcome to our 17th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. We aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia. And it's a huge pleasure for us to have Dr. Abdulsemed Mohammed here with us to give us an update on the approach and management of upper GI bleeding. To give you a little bit introduction about Dr. Abdulsemed, he graduated his undergrad medicine school at Addis Ababa University in 2012. After that, he specialized in internal medicine, also in Addis Ababa University School of Medicine. And he made his subspecialty in hepatology in Addis Ababa University. After that, he continued his fellowship or his super specialty in interventional endoscopy at University of Toronto in Canada. And he's currently an assistant professor and staff at Department of Internal Medicine at the College of Health Science at Addis Ababa University. And he's also the president of Ethiopian Gastroenterology Association. Besides that, he have made numerous research and experiences. He have published about 10 articles in local and international journals. He also have co-authored a book chapter in the 5th edition of Howey's textbook in endosonography. And this is a little introduction about Dr. Abdulsemed. I've taken quite a few times, so I give you the stage to you.
Thank you, Adam, for the kind introduction. So our discussion for today is upper GI bleeding and the approach to the management of upper GI bleeding. It will be a brief presentation, and I hope we will have a lively discussion after the presentation. This is going to be my outline of presentation for this session. I'll mention some introductory remarks. We'll see the epidemiology internationally and locally. We'll see the etiology of upper GI bleeding and initial assessment of patients and resuscitation of patients with upper GI bleeding, risk stratification, and targeted management of patients with upper GI bleeding. So as an introduction, any intraluminal bleeding above the ligament of Treitz is considered as upper GI bleeding, as you know. So the ligament of Treitz is a fibrous ligament connecting the fourth duodenum to the diaphragm. So any bleeding arising from the esophagus, stomach, and duodenum is considered as upper GI bleeding. So in general, maybe from your medical school, you remember that it's GI bleeding in general is classified as upper GI and lower GI bleeding. So any bleeding below the ligament of Treitz is considered as lower GI bleeding. But recently there are studies showing that this classification is very gross, and there is a just classification of bleeding in general: 3, upper, middle, and lower GI. So bleeding from the ligament of Treitz out to the terminal ileum is considered as middle GI bleeding. And this is usually the source of obscure GI bleeding that we'll see next. So upper GI bleeding in terms of manifestation can be overt, that is a visible, clinically visible bleeding. And this can be in the form of hematemesis, which can be red, frank red bleeding, or coffee ground emesis, which is blood which stayed in the stomach for a while. It can be dark tarry stool or melena, or in 10% of patients with upper GI bleeding, they can present with hematochezia, that's passage of red or maroon colored blood per rectum, which is a subacute bleeding, an acute bleeding. So it's a subacute or chronic bleeding, and patients usually present with anemia. And as I mentioned earlier, GI bleeding can be obscure, which is a clinically non-visible bleeding, which cannot, it's a recurrent persistent bleeding with a source not identified by a routine endoscopy, be it upper or lower endoscopy, and sometimes pushing thoracoscopy. So if there is continuous bleeding or recurrent bleeding, which cannot be identified by a routine endoscopy, is considered as obscure bleeding. And most of the cause of obscure bleeding are from the middle GI, that's from the small bowel. Clinically inapparent bleeding is occult bleeding. So what is severe GI bleeding? So when patients present with shock or orthostatic hypotension, it's classified as severe GI bleeding. Or if there is a drop in hematocrit by 6% or hemoglobin by 2 grams per DL, it's considered as severe GI bleeding. And if someone needs blood transfusion of at least 2 units of packed RBC, it's considered as GI bleeding. So coming to the epidemiology, as you know, US takes the lead in tabulating data, I would say, in almost every clinical disease. So when we look at the US data on GI bleeding, it accounts for more than 1 million hospitalizations annually, with upper GI bleeding taking the lead, accounting for 50%, followed by lower GI bleeding 40%, and obscure GI bleeding 10%. And GI bleeding in general is more common in males with 2-to-1 ratio, and it increases with age. We'll see the factors later. So this is a table showing the general cause of upper GI bleeding from the University of California, Los Angeles, recent data actually. So in this study, including nearly 1,000 patients, peptic ulcer disease accounts for the majority of bleeding, followed by viruses. And as you can see, there are a list of etiologies. So they also showed a changing epidemiology of upper GI bleeding, causes of upper GI bleeding in the US from the same center, UCLA. And if you see the first pie chart here, from 1983 to 1992, ulcers used to predominate as causes of upper GI bleeding. But after 2000s, up to 2008, ulcers, the share of ulcers in general is decreasing. And this is said to be due to widespread use of PPIs and due to widespread testing and treatment of H. pylori in the US, and improvement in hygiene and living conditions, obviously. So coming to Ethiopia, I'm sure many of you know this review, a review of 10,000 endoscopies done in Blackline. This is a 15-year review from 1979 to 1994, published in 2004 by Taye and his group. So this is a general retrospective review, and in this study, in the endoscopies done, duodenal ulcer contributed the majority of the findings, followed by esophageal varices and then gastritis. And there's a recent study from the St. Paul group by a colleague of mine, Mr. Rajani, and this study showed actually varices to be the most common cause of upper GI bleeding. Mind you, this is a hospital-based study, and this contained about 128 patients. Not a lot of patients, but fair share of patients in a tertiary setup. So varices were found to be the most common cause of upper GI bleeding, followed by peptic ulcer disease, followed by esophagitis, gastritis, and duodenitis, and malignancies. And what is surprising is the proportion of days in this study was 17%, which is pretty high, I would say. So one would mention that this is a tertiary center study, and there could be a referral bias, obviously, and this may affect the overall cause of bleeding in Ethiopia, and that would be a valid argument, because people tend to refer patients with comorbidities like cirrhosis or previous variceal bleeding or stigmatas of liver disease in general than a healthy-looking young patient with suspected upper GI bleeding. So referral bias is one issue to be considered here. Another argument would be this could be a reflection of the true population data, because there has been widespread use of PPIs and a widespread availability of H. pylori tests, and I would say a sizable population of patients with H. pylori positive tests are getting treated. So this is also another argument on the other hand. Okay, so about 80% of patients with GI bleeding are self-limited, and about 20% of patients continue to bleed. So these are the ones who actually carry a high mortality. So these are the patients who need acute medical, endoscopic, and interventional and surgical interventional radiology and surgical interventions as much as possible. So in general, the mortality combining all etiologies, the mortality rate of upper GI bleeding is 5 to 10% for the ones presenting with severe upper GI bleeding. And this number, interestingly, has not changed since 1970s. And this is mainly a Western data, obviously. And this is because of the increase in proportion of older patients in the West, and also the increase in the number of patients with cirrhosis and variceal bleeding. So coming to etiology of GI bleeding, for management purpose, and also since they have different outcomes, they are grossly classified as variceal and non-variceal etiologies of GI bleeding. So this list of causes of upper GI bleeding, we have peptic ulcers, esophagitis, gastritis, types of hemorrhagic gastritis, lesions. These are you have portal hypertensive gastropathy itself. It's commonly called anemia, but severe portal hypertensive gastropathy sometimes cause upper GI bleeding. And in critically sick patients, usually admitted to the ICU, patients can bleed from stress-related mucosal injury or stress-related ulcers. And for this, the known risk factors, the major risk factors are presence of coagulopathy for some reason, like DIC, like cirrhosis, and patients on mechanical ventilation. So these two are risk factors for stress-related ulcer development in critically sick patients. And in a sizable amount of patients, causes may not be identified. So coming to initial evaluation, and patients, whenever you meet a patient with upper GI bleeding, assessment of hemodynamic stability takes the priority, and you have to have a plan for fluid resuscitation. If there is a quick assessment, hemodynamic stability, resuscitation must be started immediately. You should secure 2 large ball IV cannulae, preferably 16 gauge or higher, into large peripheral veins, because you're going to give a lot of fluid for patients with hemodynamic instability, and also you're going to transfuse patients. And for those patients who are not maintaining their saturation, supplementing oxygen is recommended. So this is for a young, healthy individual. Estimation of blood loss, class 1, class 2, class 3, class 4, based on the amount or percentage of blood loss and manifestations. So in general, crystalloid administration for resuscitation is recommended in upper GI bleeding. And you have to draw blood samples urgently for hemoglobin. Mind you, as you know, it may be normal for the first 12 to 24 hours because the patient is losing whole blood and hemoglobin may not drop, but after due to fluid resuscitation, the hemoglobin may start to drop after 12 to 24 hours. And urea may be elevated in patients with upper GI bleeding. So elevated urea is an indicator of marked or severe upper GI bleeding. Patients with lower GI bleeding will not have elevated urea. So the blood has to be degraded and absorbed for urea to be elevated. Okay? Cross-match should be sent for transfusion, and one has to do organ function tests, creatinine, liver function test, including PT, INR. So optimal fluid resuscitation and stabilization is essential prior to endoscopy. And this is actually a prerequisite for endoscopy. So we don't rush patients to endoscopy before optimally resuscitating them and stabilizing them. Patients with active bleeding should receive IV crystalloids. Colloid administration is not, routine colloid administration is not recommended. So the go-to resuscitation is with crystalloids. And you have to be careful in patients who may be at risk for fluid overload. These patients may require intensive monitoring of fluid administration. So intubation, routine intubation of patients with upper GI bleeding is not recommended. Those patients who have severe ongoing hematemesis and or altered mental status who cannot keep their way or protect their airway should be intubated. And this should not delay delayed up to endoscopy. So patients who are vomiting a lot of blood are obviously at risk of aspiration, and patients who are agitated, especially with background cirrhosis, should be intubated immediately. Generally follow restrictive blood transfusion strategy, and this is to transfuse patients with hemoglobin less than 7 grams per DL with a target of 7 to 9 hemoglobin. Okay, but in high-risk patients like elderly patients with comorbidities like ischemic heart disease or advanced cirrhosis, class B or class C cirrhosis, transfusion threshold should be a bit higher, and target hemoglobin is around 10. So this is the landmark trial, which was published in 2013. It dramatically changed the way of transfusion in upper GI bleeding. So they had liberal versus restrictive transfusion. So liberal strategy is transfusing patients with hemoglobin of less than 9. Restrictive is, as you know, transfusing patients if the hemoglobin is less than or equal to 7. And this study showed significant overall survival benefits of restrictive blood transfusion strategy compared to liberal strategy. So in general, we follow this strategy in patients with regards to blood transfusion. But there are like patients who are actively bleeding and with hemodynamic instability despite crystalloid administration, blood transfusion should be done despite a seemingly normal hemoglobin. We all know the hemoglobin is not normal because the patient is active bleeding and the patient has hemodynamic instability. So blood transfusion should be given along with crystalloids in such patients. Platelet transfusion is not given routinely for patients. So if the platelet count is less than 50,000, platelet transfusion is warranted. Otherwise, it shouldn't be given for every bleeding patient. How about NG tube aspiration for diagnostic purpose? Like 10, 15 years ago, people used to stick a gastric tube down to the stomach of bleeding patients for diagnostic purpose. But this was shown to be less sensitive and specific for diagnosis of upper GI bleeding. So it's not recommended for diagnostic purpose. Potential benefits of nasogastric tube insertion in patients with upper GI bleeding is for those patients who are suspected to have a fresh bleeding or clots in the stomach. So this is not, it shouldn't be a regular NG tube, it should be a large ball tube because regular NG tube will not be able to clear blood clots from the stomach. So it should be a large caliber NG to remove clots or fresh blood in the stomach. This is just to increase visualization during endoscopy. So coming to risk stratification of patients before endoscopy. This is mainly used for non-variceal upper GI bleeding patients, but we don't know when patients present with upper GI bleeding, we don't know which patient has varices or not. So we tend to do risk stratification or risk scoring for every patient, but mainly this is for non-variceal upper GI bleeding patients. And this is to document or to have a sense of the mortality and rebleeding risk patients upper GI bleeding. Okay, so scoring patients, risk stratifying patients with this different scoring methods will help to triage patients to the higher available hospital care and to have sort of an urgent endoscopic intervention. So we have pre-endoscopic and post-endoscopic scoring systems. You have a well-validated Glasgow Blatchford score and clinical Rockwell score. So Rockwell score has clinical and endoscopy component. So before endoscopy, the clinical Rockwell score predicts mortality as well as rebleeding. And there is this AMS65, it's an American scoring system. The first two, Glasgow and Rockwell, are from the UK. So AMS65 can also be done to predict mortality. So after endoscopy, there are different methods like scoring systems like complete Rockwell, that's clinical Rockwell plus endoscopic findings, Baylor scoring system, Cedars-Sinai, and there are also other validated scoring systems. So this is a table showing the components of Rockwell, complete Rockwell score. So you have age, pulse rate, blood pressure of the patient, presence of comorbidities, endoscopic diagnosis, and stigmata, endoscopic stigmata of recent bleeding. So this is mainly for ulcers. Okay, so the first, age, pulse rate, systolic blood pressure, and comorbidity are clinical Rockwell that can be done pre-endoscopy, and the last two are added after endoscopy. With bleeding duodenal ulcer, about 53% of patients took NSAIDs or aspirin, and about half of the patients were infected with H. pylori, and about 10% had no obvious cause for the ulcer. So there are several causes of ulcers in the stomach and duodenum, such as Crohn's disease, such as basophilia and other disorders. So about 10% of these patients had no obvious cause. So these are predictors of poor prognosis in patients presenting with bleeding peptic ulcer. So elderly patients bleeding while in the hospital, comorbidities, hemodynamic instability. This is fresh blood in nasal NG tube, already like patients who NG you can suction, but inserting NG for diagnosis is not recommended. So this is fresh blood aspirate in NG, having coagulopathies, requirement of multiple transfusions, patients who have ulcers on higher aspect of the lesser curve of the stomach. This is because the ulcer is very close to the left gastric artery, and having an ulcer in the posterior wall of the duodenal bulb. This is because of the presence of gastroduodenal artery very close to the posterior wall of the duodenal bulb, and higher risk of endoscopic findings, like high-risk stigmata that we will see later. So this is a Forest classification of endoscopic stigmata of recent bleeding from ulcers. I'm sure you know, you remember this. Class 1A is a spurting hemorrhage. 1B is just oozing from the ulcer. Class 2A is non-bleeding visible vessel without clots or bleeding. 2B is an adherent clot, and C is a hematinic spot. This is a flat spot. And class 3 is a clean based ulcer. Actually, class 3 is the commonest finding during endoscopy, especially in patients who took PP. So in general, class 1 and 2 are generally considered as high risk for recurrent bleeding or rebleeding. This is an endoscopy picture showing a spurting ulcer. This is 1A. I have not included 1B picture here. This is a non-bleeding visible vessel, as you can see here, with a spouting of the vessel within the ulcer. This is a large adherent clot, and this is a kind of a clean-based ulcer, but with a spot at the center of the ulcer. And this is a clean-based ulcer. This is a class 3 ulcer at the posterior wall of the duodenal bulb. This is the anterior wall. Actually, you can see small ulcers here and here. This is the D1, D2 junction, and this is the anterior wall, and this is the posterior wall of the duodenal bulb. So based on Forest classification, the risk of rebleeding you see here. So if a patient has class 1A ulcer, then risk of rebleeding is 90%. So almost all patients rebleed if no intervention is done. But if the endoscopic intervention done for these patients, the risk of rebleeding markedly decreases by 1/3, so up to 15%. So you can see the need for endoscopic intervention in patients with high-risk stigmata. So if someone has a visible, non-bleeding visible vessel, the risk of rebleeding is 50%, and endoscopic intervention reduces it to 15 to 30%. Those with flat spots and clean-based ulcers have low risk of rebleeding, 1% and 3%, and endoscopic intervention is not required because risk of rebleeding is low. So coming to endoscopic treatment options for ulcers, we have injection therapy. So this can be done with normal saline or dilute epinephrine. I personally tend to use dilute epinephrine because it has two benefits. One is a tamponade effect, and the other benefit is local vasoconstriction effect. So the tamponade effect can be achieved by both normal saline and dilute epinephrine, but the local vasoconstriction effect is achieved with dilute epinephrine. So we I usually use 1 to 10,000 dilution or 1 to 20,000 dilution of epinephrine and inject around and into the bleeding ulcer. Sometimes you can use sclerosants. This causes direct tissue injury and thrombosis of the culprit vessel. And there are also other options for injection like thrombin, fibrin, and glues sometimes. So this leads to a primary tissue seal in such patients. The other option for management is thermal coagulation. So this can be a non-contact thermal coagulation of ulcers. You can use a ND-YAG laser or argon plasma coagulator. This is basically a non-contact method for control of bleeding. And the other thermal coagulation is contact. So you can use a heater probe or bipolar coagulation. So we have bipolar coagulation, and it's one of the most effective ways of controlling a bleeding ulcer. Another alternative is mechanical therapy. So this can be done with clips, or sometimes for a small bleeding ulcer, you can also apply band ligation. But clips are the ones which are widely used. So how about second look endoscopy? If a patient is not rebleeding and if the patient is not having hemodynamic instability, relook endoscopy is not recommended. So repeat endoscopy is recommended for patients who have evidence of recurrent bleeding, or for patients with gastric ulcers. Repeat endoscopy is recommended to be done 8 to 10 weeks to document ulcer healing, and if the ulcer is not healed, to take biopsies from the edge of the ulcer to rule out malignancy. So for those patients who have oozing ulcer, that is a class 1B ulcer, you can do epinephrine injection, monotherapy, but that's not recommended nowadays. So you have to combine it with a mechanical therapy with clips, and this will decrease the rebleeding rate to less than 55%. That is the rate you see in patients with clean-based ulcer. So clean require endoscopy, and they do not require relook endoscopy, and these patients can be discharged with oral medications. So the rationale behind pharmacotherapy, especially with PPI, is to increase the intragastric pH above 4, ideally above 6, because this will, increasing the pH will enhance platelet aggregation and plasma coagulation. So you have to be able to consistently keep a higher intragastric pH, and this has been shown in different studies to be rendered by PPIs. So that's why we do not use actually H2 receptor blockers, because there is a chance of tolerance with continued use, and they do not consistently keep the intragastric pH above 4 or 6. Okay, so this has been shown to decrease the rebleeding rate in studies coming from India and China, Hong Kong. You can choose whichever way or method of administering PPIs, but it should be high dose. Okay, so it should be high dose, but regardless of the route of administration. Okay, so if there is no IV PPI in your setup, you can give high dose oral PPI, and studies from India showed similar outcomes actually. So if with regards to IV, should it be a divided dose or like giving a bolus dose and continuous infusion? There is no stark difference between the two. So you can give divided dose, which is usually easier to be administered. Or if you have the setup, you can load the patient with high dose like 80 milligrams and then give 10 milligram per hour infusion. So this is basically what you should do. So patients with high-risk stigmata, so active bleeding or non-bleeding visible vessel, they just needs endoscopic intervention, and the patient should be on PPI, and they should be hospitalized at least for a day or two to watch for rebleeding. And patients with adherent clot, as I said, endoscopy can be intervention can be done, or then the endoscopist can say let's watch the patient for rebleeding. Either way, the patient should be on PPI and the patient should be hospitalized. Patients with 2C or a class 3 ulcer, then no endoscopic intervention is warranted, and the patient can be discharged with oral PPI. Okay, so use start in variceal bleed, although it decreases spontaneity, is recommended for patients with non-variceal bleeding. Okay, so patients who fail endoscopic therapy, so that is recurrent bleeding after 2 sessions of endoscopic intervention, are classified as having refractory bleeding, and these patients should be referred for interventional radiology if the service is available, or to surgery, because these patients are at high risk of dying. So coming to varices, in our setup, these are in tertiary centers, these are the most common cause of upper GI bleeding, as you see the data. And compared to ulcer bleeding, they carry a higher mortality rate. So with each episode of bleeding, there is a mortality rate of 30%. And so there is a rule of 30%. 30% of patients with cirrhosis present with variceal bleeding, and with each episode of bleeding, there is a 30% risk of mortality, and a 1 year risk of bleeding at 30%. So this is the rule of 30%. And there is the long-term survival of patients with varices is very low compared to patients with non-variceal bleeding. Okay, although this depends on the MELD score and Child-Pugh class of the patient. So, coming to medical management, these patients should be started with somatostatin or octreotide or terlipressin. This is a vasopressin analog. And this has been shown to be as effective as sclerotherapy for control of variceal bleeding. And of course, this is an adjunct to endoscopy, and this should be continued for 3 to 5 days. And the mechanism of this is actually by decreasing splanchnic blood flow and decreasing intravariceal pressure, and thereby decreasing bleeding. Okay, so this has been shown to decrease mortality in patients with upper GI bleeding, variceal. Okay, so patients with cirrhosis should be given antibiotics. All patients with cirrhosis with variceal bleeding should have should get antibiotics at presentation. Okay, and this decreases mortality and also bacterial infections. As you know, patients with upper GI bleeding has with background cirrhosis have increased risk of infection, SBP, and also other infections like pneumonia. So antibiotics should be given for all patients with cirrhosis and varicose bleeding. So other alternatives like balloon tamponade is rarely used, and this is used to stabilize patients whenever endoscopy fails. So this technique is only used for 12 to 24 hours as a bridge therapy before sending the patient to TIPS or surgery. Okay. So band ligation is actually the preferred intervention for treatment of variceal bleeding. It reduces the risk of rebleeding, overall mortality, and death compared to sclerotherapy. The problem is doing endoscopic band ligation or variceal band ligation requires visualization of the varices, and this is difficult during active bleeding. So if the patient is actively bleeding, the endoscopist may resort to sclerotherapy, which is actually similar in terms of controlling the bleeding, but the rate of rebleeding is slightly higher, and the side effects like developing post-sclerotherapy ulcers or strict long-term strictures is higher compared to variceal band ligation. Okay, so the other option in patients with active bleeding with varices is to perform a 4-quadrant ligation. So even if the varices are not clearly visualized, the endoscopist will do ligation of the varices at the G junction in 4 quadrants. This is because in general, blood flows from below, from the G junction to up to the esophagus. So if the varices are ligated around the G junction, blood flow to the proximal varices will decrease, and hence bleeding decreases. The other therapeutic intervention in patients with variceal bleeding is TIPS. So this is transjugular intrahepatic portosystemic shunting. This is mainly for patients with refractory variceal bleeding. Again, this can be done if endoscopy fails right away, or if TIP service is not available, you can insert balloon tamponade and send the patient to a center where TIPS is available. Okay, so in our center setup, since TIPS is not available, we put a zinc-staken Blakemore tube, that's tamponade, balloon tamponade, and hope that the bleeding will stop, and we remove the balloon after 12 or 24 hours, and then we do band ligation. Okay, this balloon again is not available everywhere. So to my knowledge, I think it's only available in 2 centers in Addis. So the other option is portosystemic shunt surgery. We actually have professionals who do this surgery, especially for patients with non-cirrhotic portal hypertension with varices. So what they do is do splenectomy, devascularization, and sometimes shunting of the portal circulation into the systemic circulation. There are different ways. So this in general is reserved for patients with recurrent bleeding or refractory bleeding. And the last resort is esophageal transection in patients with variceal bleeding. This is a very old school intervention. So patients with massive exsanguination and refractory bleeding, refractory to endoscopy, refractory to balloon tamponade, then surgery will be done, and the esophagus will be transected, and the vessels, the varices will be ligated, and maybe reconnection surgery will be done later. That's all. So this is a brief presentation about upper GI bleeding approach and management. So if you have questions, you're welcome. Good to see all those doctors joining from different parts of Ethiopia. It's a pleasure for me actually to connect with you and share my experience. Alamu asked the role of tranexamic acid in acute upper GI bleeding. So this is actually a disappointment. So there was a large trial for administration of tranexamic acid. It's an anti-fibrinolytic agent, and the outcome was disappointing. So it did not show any benefit. So the ASGE, the European Society for Gastrointestinal Endoscopy, ASG, ACG, all the major guidelines actually recommend against use of tranexamic acid in patients with acute upper GI bleeding. Okay. So role of beta blockers in patients with viruses. This is not for acute GI bleeding. It's for primary and secondary prophylaxis. So this is beta blockers do not have benefits in the management of acute variceal upper GI bleeding. So patients with high risk stigmata varices on endoscopy and with background cirrhosis, you can give beta blockers, non-selective beta blockers. We have alternatives now. You can give propranolol or carvedilol. In recent studies, carvedilol was found to be better than propranolol or nadolol. So you can prefer whatever is available and within the reach of the patient's pocket. And this is, as I said, mainly for primary and secondary prophylaxis. Okay. So trauma, yes. So like esophageal rupture, esophageal ASD, doing AMR from the esophagus can cause upper GI bleeding. I wanted to show you a picture, but I couldn't. So a video actually. So a patient, I recently saw a farmer from the rural, from a rural area presenting with upper GI bleeding, and we saw a live foreign body, which is a leech in the oropharynx, and that was a leech infestation causing upper GI bleeding. We actually saw 2 cases within a month with leech infestation, young old patients actually. So leeches usually cause anemia, so they're not known to cause massive upper GI bleeding, but this patient is present with overt upper GI bleeding. So you have a list of different causes of upper GI bleeding, including trauma, leech, caustic injections, peels, and so on. Okay, hope that answers your question. Is there any direct relationship between patients with bleeding disorders and upper GI bleeding and preventive methods? So patients with, for example, thrombocytopenia, be it from ITP or TTP, can present with mucosal bleeding. Like if they can have upper GI bleeding, they can have lower GI bleeding. So, of course, coagulopathies can lead to upper GI bleeding. And your second question is, why is not NG tube aspiration diagnostic? Because one, in several studies showed that the positive predictive value is good. So if you aspirate blood, it confirms upper GI bleeding. But in about 15 to 20% of patients with upper GI bleeding, NG tube aspiration may mislead. So it could be a negative aspirate or a bile aspirate for that matter. Okay, so this is not a good diagnostic tool. So it's not recommended. As I said, the recommendation for NG tube insertion is to clear fresh blood or clots in the stomach prior to endoscopy. Okay. Do you treat angiodysplasia in our setup? Yes, but we don't have the optimal treatment modality. So the preferred treatment modality for angiodysplasia is argon plasma coagulation. So we don't have that in our setup yet, but I've had a few patients with bleeding gastric and duodenal angiodysplasia. So I did a monopolar coagulation of the angiodysplasia, and one patient had recurrent bleeding even after monopolar coagulation. So I did band ligation of the angiodysplasia, and after that, the patient had a cessation of the bleeding, actually. Okay. So what is the problem if the goal of hemoglobin is greater than 10? So again, I have to refer you to that trial showing restrictive blood transfusion strategy beta. So if you transfuse a patient with multiple units of blood, there are risks associated with blood transfusion, risk of infection, risk of transfusion reaction, acute lung injury, transfusion-related lung injury. Okay, so these all come with transfusing multiple units of blood to patients. So having a lower threshold is recommended for patients who are not at high risk. So the high risk patients are those elderly patients with comorbidities or advanced cirrhosis. For those patients, you can aim a higher target, okay? All right. So role of omeprazole and Plavzil in active variceal bleeding before endoscopy. So PPI has no role in management of variceal bleeding, okay? So in fact, in patients with suspected variceal bleeding, there is no role for PPI administration, okay? In fact, there are guidelines which recommend against routine administration of PPI before endoscopy, okay? But ESG, the European Society for Gastrointestinal Endoscopy, recommends giving PPI before endoscopy, that is before knowing the exact etiology of the bleeding. So it does no harm, but there is no benefit in giving PPI for variceal bleeding, okay? But in patients who underwent band ligation, okay, for a bleeding varices or whatever, elective band ligation of varices, PPI should be given for 2 weeks. This is to decrease bleeding from post-ligation ulcer, okay? But this is a different scenario. Okay? So Plavzil is recommended, either erythromycin or Plavzil. These are prokinetics. It should be given for patients with upper GI bleeding before endoscopy. That's half an hour to an hour before endoscopy. And this was shown in different studies to improve endoscopic visualization, okay? But it does not affect the outcome or survival of patients. One may choose not to give erythromycin or Plavzil before endoscopy. That's left to the discretion of the endoscopist, but it was shown to improve endoscopic visualization and to decrease the need for relook endoscopy, because the first endoscopy will be satisfactory to evaluate the stomach and the duodenum, okay? So critical illness ulcers, as we said, are causes of bleeding in critically sick individuals, usually admitted to the ICU. And the major risk factors are presence of coagulopathy and being on mechanical ventilation. And these ulcers usually do not present with massive upper GI bleeding, okay? And they may not require endoscopic therapy. But those who present with massive upper GI bleeding should should have endoscopic intervention done. And sometimes the endoscopic lesions, the lesions you see on endoscopy may be diffuse, and applying clips or thermal coagulation may be difficult. But for such patients, there are other interventions like hemospray. That's like a powdered hemostatic, it's a hemostatic powder. It's not available in our country. And for such patients with diffuse mucosal bleeding, hemospray can be applied, but they do not usually present with massive upper GI bleeding. Okay. So better scoring system for patients with upper GI bleeding pre-endoscopy, I would say, is the Glasgow-Blatchford score. In fact, both the American College of Gastroenterology and the European Society for Gastrointestinal Endoscopy recommend GBS score before endoscopy. So I would say to go for GBS score, okay? But the Americans may say otherwise because they developed the AIMS score. So as I said, AIMS score is better in terms of mortality prediction. But Glasgow-Blatchford score is better in terms of identifying patients who require endoscopic intervention or hospitalization. So patients with GBS score of 0 and 1 can be discharged and treated as an outpatient or have endoscopy as an outpatient. So one thing I would like to stress is patients, almost like all patients with upper GI bleeding should have endoscopy done if the service is available. Okay? So that should be a routine evaluation for patients. Keeping NPO versus oral PPIs. So NPO is mainly for endoscopic intervention, and of course prevention of aspiration in patients who have repeated emesis or vomiting. Giving PPIs with a small amount of water is not going to be a problem. Okay, so if there is no IV PPI in your setup, you can give oral PPI with a small, maybe 20-30 ml of water, and that's not going to intervene with endoscopy or risk the patient for aspiration. Okay, so patients. Okay, so how do you? Someone asked, how long do you recommend to keep patients NPO with upper GI bleeding? So this is until endoscopy is done. Okay, so keeping the patient NPO for about 12 to 24 hours is not going to harm the patient. Okay, so endoscopy, as I said, early endoscopy is recommended to be done within 24 hours. It doesn't mean it's like exactly within like 24 hours mark. So it can be done within 12 to 24 hours. Okay, so you can keep the patient NPO from 12 to 24 hours. And after endoscopy is done, and after you know the exact etiology, and if endoscopic intervention is done, NPO can be, like, for example, if varicella ligation is done, you can keep the patient NPO for 3 to 4 hours, then start liquid diet and soft diet afterwards. Okay, if the patient has clean-based after endoscopy, you can start the patient on oral feeds. Okay, there's no problem because the risk of rebleeding is very low. Okay. Antibiotics, again, very good question here, Dr. Getachew. Antibiotics for variceal bleeding without ascites. So it should be given for patients both for compensated and decompensated cirrhosis. So even if the patient does not have ascites, if the patient has cirrhosis, antibiotics should be given. Okay. So what's the maximum times of doing band ligation? How many times you repeat it? Okay, this is a good question. In general, studies show, so if you commit for band ligation, it shouldn't be a one-time treatment because you cannot eradicate varices with one-time band ligation, okay? So it should be done repeatedly, and the average time of or sessions of ligation is usually from 4 to 6 times. Okay, so you do band ligation now, repeat it in 7 to 10 days again, then 2 weeks, then 1 month, then maybe the 4th, 5th session in 2 months, and then follow the patient after 3 months for varicella development. And this patient should be put on beta blockers. Okay, even if the varices are obliterated or eradicated, the patient should be on beta blockers, and the patient should have surveillance endoscopy in case the varices reappear. Okay, so patients with Mallory waist tear should be managed just like other patients with upper GI bleeding. Okay, so about 90% of patients with Mallory waist tear actually heal by themselves. They do not require endoscopic intervention. Okay, if they require endoscopic intervention, then patient can be after endoscopic intervention can be restarted on liquid diet and then advance the diet accordingly. Okay, but they should be kept in PO until endoscopy is done. So for how long should we give PPI after endoscopic intervention? So for patients, so we did not talk about H. pylori eradication. So what I'm telling you the WHO recommendation. So patients with ulcers, duodenal or gastric ulcers, in areas where H. pylori is prevalent, like ours, empiric H. pylori therapy is recommended. Okay, so go ahead and start the patient on triple therapy. If the patient is not treatment experienced before, or alter your therapy if the patient has had a treatment therapy before, treatment experience before. So after that, PPI should be continued for 6 to 8 weeks, okay? Because that's usually the time required for complete healing of ulcers, okay? For patients who are going to be on anticoagulation, like aspirin or a dual antiplatelet therapy, PPI should be continued indefinitely, okay? Because these patients developed ulcer and bleeding while they are on anticoagulation therapy. So one important thing to mention here is, how about patients who are presenting with upper GI bleeding and who are on anticoagulation therapy? So in general, patients who are on aspirin alone, if they present with upper GI bleeding, do not discontinue aspirin, okay? This is a general recommendation. Some guidelines say if the aspirin is for primary prophylaxis, discontinue and restart after 5 to 7 days. But if it is for secondary prophylaxis, do not discontinue, but the general recommendation is do not discontinue aspirin, okay? But patients who are on dual antiplatelet therapy, like aspirin and clopidogrel, do not discontinue aspirin, but discontinue the second antiplatelet agent, usually clopidogrel or prasugrel, and have a discussion with the cardiologist, okay? This is very important, very important. And all other patients who are on other types of anticoagulants, like warfarin, like newer anticoagulants, rivaroxaban and so on, should be discontinued, and they should be restarted as soon as possible after endoscopic hemostasis is achieved, okay? This is the recommendation, and this is very important, okay? So antibiotics is recommended for 5 to 7 days in patients with cirrhosis and upper GI bleeding. It was excellent interacting with you guys all. There are a lot of amazing questions here. I can forward my email if you have burning questions and if you want to contact me. So I think Adam will share my email if if you want to forward questions. Thank you very much.